Welcome to this medicine masterclass in which we'll be discussing bronchiectasis and cystic fibrosis. Bronchiectasis is an abnormal, permanent thickening and dilatation of the bronchi and bronchioles due to repeated infections, impaired drainage and airway obstruction due to a defective host response. This will result in symptoms such as shortness of breath, a chronic productive cough of thick, smelly, purulent sputum, hemoptysis, recurrent infections, pleuritic chest pain, weight loss, and in some conditions, a history of childhood infections, sinusitis, and subfertility. The common organisms that cause infections in such patients include Staphylococcus aureus, Haemophilus, and Pseudomonas aeruginosa. These are particularly aggressive organisms. Moreover, Burkholderia cepici has a worse prognosis and can be a possible contraindication to transplantation. The signs that you would find in such patients are copious purulent sputum that you would see in a bedside sputum pot. Due to the chronicity of the condition, finger clubbing, that's a swelling of the terminal phalanges of the digits with loss of the normal angle between the nail and the nail bed, a normal apex beat and expansion, bilateral coarse late inspiratory crackles and wheeze, and they may have central or peripheral cyanosis. The causes include COPD, can be post-infective, certain bacteria such as TB, or viruses such as measles and HIV or ABPA can cause bronchiectasis. There are congenital diseases such as cystic fibrosis and Cartagener's syndrome. Cartagener's is associated with dextrocardia or complete situs inversus along with sinusitis and infertility. Immunodeficient patients, those with HIV or hypogammaglobulinemia, can also have bronchiectasis, and certain connective tissue diseases such as rheumatoid arthritis or systemic lupus erythematosus can also increase the predisposition to bronchiectasis. Yellow nail syndrome is a present of yellow nails with bronchiectasis, lymphedema and pleural effusion. And Young syndrome is as a result of mercury intoxication, bronchiectasis and infertility. There are clinical clues that can point you towards the etiology. So if the patient has bronchiectasis as a result of cystic fibrosis, they may be young, thin, short, they may have a PEG tube or along with a portacath or a Hickman line, along with signs of chronic liver disease too. Cartagener's patients would have dextrocardia, and yellow nail syndrome, the patient would have obviously yellow nails. There's a number of investigations that patients with bronchiectasis require. Bloods are very important to determine the white cell. The differential is important, particularly if there's an eosinophilia. This may guide you towards a fungal etiology. An anemia of chronic disease may exist. A chronically elevated CRP would suggest chronic infections. Immunoglobulins, particularly a reduction in hypogammaglobulin, would suggest a predisposition to bronchiectasis. An autoimmune screen looking at ANA, RF, anti-CCP to look at an associated rheumatological condition, a HIV test to determine whether there's any immunosuppression from AIDS, aspergillus precipitans and IgE levels, as well as quantiferon for TB, can also facilitate the detection of the etiology. It's important to check the sputum MCNS and AFB cytology in these patients to help guide optimized treatment. An ABG is an important blood test to determine the degree of respiratory failure, to determine whether or not non-invasive ventilation is required for these patients. And an ECG in chronic disease would demonstrate right heart strain as a result of chronic hypoxemia and cor pulmonale. Other investigations radiologically, a chest radiograph would demonstrate cystic shadows and thickened bronchial walls, what we call tramline and ring shadows. A HRCT would also demonstrate this in more detail, where you'd have a tram track sign, thickened walls, balloon cysts and bullae, and you see dilatation of the airwaves. Just be aware that HRCT is much more useful in picking up bronchiectasis. A standard CT resolution is approximately 1 centimeter thick, whereas HRCT slices are 1 to 1.5 millimeters and spiral CT is an evolving CT technique which allows contiguous sections. So it's important you choose the right investigation. There is a classification called the Reid's classifications of bronchiectasis, which has been around since the 1950s, which helps you determine what type of pathological changes are present. In cylindrical bronchiectasis, you have uniformly dilated bronchi. In varicose bronchiectasis, there are dilated bronchi with irregular bulging, varicosities. And in cystic or saccular bronchiectasis, it is a severe form of sharply reduced bronchial subdivisions and dilated bronchi endings in cystic pus-filled cavities, which requires more aggressive treatment. Remember that cystic fibrosis is an important cause of bronchiectasis. Cystic fibrosis is an autosomal recessive disease due to a defect in the CFTR gene located on chromosome 7. The most common mutation is that of delta 5 F08, which codes for the CFTR protein. A defective CFTR protein leads to thick, viscous secretions which enable colonization of opportunistic infections and can block lumens. There are other complications of CF, not just bronchiectasis, but pancreatic enzyme insufficiency, diabetes, gallstones, biliary cirrhosis, subfertility, sinus disease, as well as osteoporosis. Now, to manage patients with chronic infections, chronic bronchiectasis, there are conservative medical and surgical options. Conservatively educate the patient, in particular, advocate the importance of smoking cessation and facilitate that process. Offer annual influenza pneumococcal vaccinations, regular chest physiotherapy and breathing exercises, postural drainage and inspiratory muscle training, and optimize their nutrition. The patients medically would require antibiotics, acute and prophylactically, and they may require oral, intravenous, or nebulized forms of antibiotics. The patients would require bronchodilators, steroids, mucolytics, and if there is a clear etiology, that would require treatment. So, for example, they may require immunoglobulins if they have hypogammaglobulinemia, and any infections that occur as a result of this should be treated appropriately and in a timely fashion. If they develop cor pulmonale, then that would require treatment, specific treatment from a heart point of view. Surgically, if there's a localized disease, there may be an option to offer a lobectomy or a bullectomy, but if there's advanced disease, which is throughout the lung parenchyma that you would see in alpha-1 antitrypsin deficiency or in cystic fibrosis, the patient may require a lung transplant. And if they've had a lung transplant, you may see the clamshell incision. Thank you for attending this medicine masterclass.